Thank you everyone for joining today. We'll get started in about a minute here. All right. Thank you all for joining us today. I'm excited to welcome you to our Heart Failure Education Initiative Lunch and Learn titled Beyond the Bedside, the Homestead Project and Innovative Approaches to Monitoring and Managing Heart Failure Patients. This event is made possible through the American Heart Association's Heart Failure Education Initiative, which is a 3-year initiative supported by Abbott that's focused on the rising need for advanced treatment pathways and education beyond guideline-directed medical therapy. We're providing a number of education events throughout the duration of this initiative, and I'd encourage you to visit the QR code at the screen to learn more. As part of this initiative and in support of Heart Month, we're excited to be hosting 2 additional events throughout the rest of the month as part of a Lunch and Learn series each Thursday in February. I'd also welcome you to scan the QR codes on the screen to register for the upcoming events or access the registration flyer in the resources tab on the Zoom platform as well. Before we begin, I'd like to quickly review how to use the platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captions, please click on the closed caption button found on your screen. Throughout today's presentation, you'll have the opportunity to submit text questions to our presenter using the Q&A feature on your control panel. You may send in your questions at any time and we'll review them at the end. The PDF of the presentation will also be available in the resources tab or in the chat. Finally, this event will be recorded and available within the coming weeks through both the Zoom webinars platform and on our heart failure education website. I also wanted to take a moment to remind you that the recommendations and opinions presented by our guest speaker may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any product or device. And with that, I will turn it over to our presenter today, Dr. Howie Tran from the University of California, San Diego. Oops. Let me make sure you can share your slides, Dr. Tran.
Okay. Thank you, Kelsey. Can you see that?
Yep.
All right, excellent. All right, good afternoon, everyone. My name is Howie Tran. I'm a transplant cardiologist at UC San Diego. And welcome to sunny San Diego. It's pretty cold today. We're about 72 degrees, 75 degrees. So that's why I'm wearing this jacket. But we're going to talk a little bit about what we've done here with what we call the Homestead Project. And it's an idea of getting a lot of our patients out of the hospital safely and monitoring them out of the hospital. So the great majority of this talk will be centered around the tools that we have. You heard about some of these tools already last week, but what we're going to do today is to specifically take a look at what we've done here in San Diego to really bring down readmissions and also bring down length of stay. Oftentimes, they're not juxtaposed like that. So I'd like to introduce the Homestead Project to you. And here is a quote that I like a lot. It doesn't make sense to hire smart people and tell them what to do. We hire smart people so they can tell us what to do. That's obviously by Steve Jobs. You're going to see that around here a lot in UC San Diego, is that we each have our own projects we're pushing us through. This is my team's project. You'll see part of my team members at the end of the slideshow, which obviously we wouldn't be able to get things done without these members as part of the team. And we get this a lot. You may get this at your academic centers as well, too, or your tertiary centers that receive a fair amount of advanced heart failure patients. But this is just a mocked newspaper page of the types of patients that we get. On the left-hand side, you get a patient that's from Newport Beach in Orange County that is coming to San Diego with an Impella 5.5. On the right-hand side, in Escondido, which is about 30 minutes from here, 48-year-old woman with a history of breast cancer and anthracycline therapy coming over here with an intra-aortic balloon pump. So these are types of patients that we get called every single time. And I was recently on service here in La Jolla and just getting a ton of these calls. But unfortunately, there's multiple delays of getting these patients here. And a lot of our patients end up going elsewhere or they die at these referring centers, community centers. And that's something that we really endeavor to change. Just like your hospital system, we have a hospital issue of beds. So EDIP means emergency department inpatient. These are patients that have been admitted from the emergency department, and we're at 75. This is as of yesterday. So these numbers as of yesterday. And as you can see in our three hospital campuses, La Jolla, Hillcrest, and East Campus, La Jolla is completely packed, and we're projecting to be pretty heavy until towards the end of the weekend here. And then where I'm at right now, physically, I'm at East Campus, our newer hospital, and you can see that we have some beds, but not many. So there's a fair amount of bed shortage issues, and more patients, more and more issues are going to pop up. This is our La Jolla campus. We're running over capacity. We're taking a look at 80% as the optimal utilization. You can see the bed utilization is above 90% or so in FY23. You can also see the ED bay utilization of beds as well too. A lot of ED patients, but a lot of observations in bays. So it's not that we're not observing our patients a lot. We're just not having enough of beds all around. And you can see on the bottom here, procedure capacity, still really high utilization, particularly for the cath lab. The cath lab is pretty high in utilization and imaging capacity as well too. So high across the board. We've got to do something about our inpatient setting. What we ended up doing is we built out downtown, which is our Hillcrest campus, which is here on the left. And where I'm at right now is East Campus, and that's a campus that we recently bought. So this is starting to become a real estate problem. Are we going to get enough beds? We tried to fix a where our patients are able to go, right? But it's robbing Peter to pay Paul. So we're taking a lot of our transplant patients, we're training our hospitalists, we're training a lot of our intensivists to take on some of these patients as well too, burping the system and getting them out of the heart failure service, which is inundated currently. So uh, again, we're just shuffling around resources. And this really got us to the idea of can we treat our heart failure patients safely at home? One of my good friends and colleagues, Dr. Ben Yehuda, had shared with me multiple times that if patients have toilets at home that they can urinate into just as well as in the hospital. So that's the challenge. The challenge is, well, can we identify a group of patients? Can we apply a workflow that we watch after these patients while they're at home? We know that these numbers, they've been with us for about a decade and a half, but these numbers are true numbers. We have about 6.2 million patients with heart failure in this country, now about 7.7 in the latest iterations of these numbers. We have about 300,000 patients who die of heart failure annually, and 50% mortality within 5 years of the diagnosis, and it's costing us $3.1 billion. This is the highest readmission rate of all heart failure, and heart disease has overcome coronary disease as the number one killer across the country. This is the impact. We are roughly about here. So the current numbers are about 7.7 million patients. We're annualized to about 8.5, almost 9 million patients by 2030. And that's almost a 50% increase from when this paper came out. The latest information from the 2026 H8 data is 7.7. So we're actually ahead of that pace when we're taking a look at 2021, 2023. So we're ahead of that pace in terms of patients getting diagnosed with heart failure. So this isn't going to end. And we have a huge baby boomer population, health and nutrition examination survey, where a lot of our patients are going to end up in the hospital with heart failure issues. So we have to prepare for that. About 70 billion or so, as we annualize to 2030, $70 billion are going to be spent on heart failure alone. That's almost twofold higher than 2013 when this paper came out. So very numbers. Part of the reason why we're dealing with this is a study that, a retrospective analysis that my friend, Dr. Anu Alala, took a look at when she was a fellow. But she took a look at two studies, DOSE and CARESS, and she took a look at how we discharge patients. 90% of patients come to the hospital because of some sort of congestion. At discharge, taking a look at dose in the CREST trials, I won't go through those trials because that's not germane to our talk, but about 40% of them had moderate to severe congestion based on our orthopnea plus edema index. And so about 40%, 60% had absent or mild congestions, but if you follow those types of patients within 60 days, almost half of those patients had some form of congestion. So currently, we're discharging our patients that are coming back to us way too quick. So this is that readmission story, right? And in our clinics, when we see our patients, we tell them, well, this is a funny cartoon, but no, it's not water. You seem to be retaining food. It's difficult sometimes to figure out if a patient really truly has volume overload when they're coming back to the clinic. And I'll share with you what we do here. And what we tried to do, this has been about a year or so, but innovation, education, evidence-based practices, we aim to enhance patient outcomes by providing comprehensive and compassionate care model, driving the delivery of healthcare at home instead of hospital, hence Homestead. And so this is our project that's been live for about a year or so. And our goal is to keep our patients at home. Let's talk about the early lessons of remote monitoring. We'll talk about some of the devices to detect decompensation. I won't spend too much time on that. You had that last week. And we'll talk about our game plan, the strategies to prevent and treat congestion. And then I'll introduce you to our Homestead project. Remote monitoring. Well, I always like to tell stories, and any of my residents and fellows know this, that oftentimes I'm very long-winded. And if I do start off with a story, there's probably something that I'm going to tie into the lesson that I wanted them to learn. So the lesson we want to learn today is that we have a 72-year-old gentleman with an LVF of about 30%. He has CRT and a defibrillator. He has hypertensive disease, chronic kidney disease, and diabetes type 2. He's not on insulin. He has hyperlipidemia. He was evaluated at our cardiomyopathy clinic after his second readmission for acute concomitant heart failure in the last 2 months. He detested being in the hospital every single time he's in the hospital. He's been on sacubitril valsartan, moderate dose. He's on empagliflozin at 10 milligrams, carvedilol at 25 milligrams twice a day, spironolactone 25 milligrams daily. He's also on atorvastatin, aspirin, bumetanide, going from 1 to 2 milligrams twice a day. He lives in Escondido, which is about 25 minutes away from East Campus, about 40 minutes away from La Jolla. And he was seen in La Jolla. What can we do to decrease his risk of heart failure related emissions? I want to keep him home in Escondido the best that I can. Well, we've learned about this. That's the challenge for us. We've learned that remote monitoring is difficult. We know the problem. We want to keep our patients at home. Let me share with you another story. The Maginot Line is something that you may or may not have heard about. Many of you may have visited the Maginot Line in France. But after the First War, after the First World War, obviously it wasn't called World War I at the time, but when France was invaded by the Eastern forces, what ended up happening was that the French said, okay, never again. This is a huge European war. We're going to build up a line of defenses to stop anybody coming east to invade France again. So there were fortifications and obstacles and weapons that were installed back in 1930s. This is a cartoon of what it looks like, but many of us have been there and visited the same bunkers. So they had French soldiers that were inside these bunkers, very heavily fortified with guns and turrets and all that. But this is what it looks like in these bunkers. So the soldiers slept there. They communicated there and kept a lot of their ammo stores. So the idea is to really try to support that. And this is what that line is. That line is right over here in the eastern part of France. Here's where modern day Germany is, and there's Italy down there. So what the thought was that if there are any forces that are coming east, they'd have to scale the mountains and go through Luxembourg, Belgium, which is highly unlikely. Unfortunately, what happened during the Second World War was the Blitzkrieg, and that's exactly what happened, was that the Eastern forces went north and east and invaded France. And within several weeks, Paris fell. And so I illustrate that story just to say that even though we think we have the right solution, it may not be the right solution. We have to think out of the box a lot of times. And back in the 90s, we thought we had the right solution. And this was a wonderful study at Washington University. This is a study taking a look at elderly patients who had heart failure who were admitted. And the idea is after they were discharged or at the time of discharge, we'll have a battery of interventions for these patients before discharge and during discharge. And that's nursing directed, a comprehensive education for the patient and the family, a prescribed diet for the family, for the patient, social services and consultation for the patient and family, and review medications, and very intense follow-up. And what we found was, boy, these patients being readmitted, the treatment group, these patients that were sent to a more uh, intense battery of intervention tend not to come back to the hospital. That was a very good thing. We thought we were onto something until we started to apply it across the board. TELE-HF, BEAT-HF, TIM-HF1, and TIM-HF2 subsequently followed, but unfortunately, none of these studies really found benefit. And in fact, we employed some of our ICDs as well too. And using our ICDs, trying to figure out thoracic impedances didn't really help either. Let's take a look at that study. The first study here is the TELE-HF study. That's over 1,600 patients hospitalized for heart failure. We ended up telemonitoring these patients, right? So heart failure heart failure hospitalization within the last 30 days. They had daily calls every single day by a nurse for 6 months. Either a diuretic was applied for them or an increasing diuretic, changing their diet, or having a doctor give them a call based on triaging. Some of these questions that were asked: have you felt more short of breath in the last day? Have you noticed more swelling in the last day? Did you wake up short of breath last night? What is your weight? Do you have any depressive symptoms? What we found was that there wasn't a difference between patients that were in the telemonitoring group versus the usual care, even in these daily call groups. And BEAT-HF was a randomization of 1,400 patients to phone calls and health coaching. And unfortunately, this didn't improve outcomes either. Heart failure hospitalized patients at the time of discharge ended up getting enrolled. There were 9 phone calls within a 6-month period. There are 3-step intervention, that is to say, taking a look at pre-discharge heart failure education, scheduled telephone coaching, and daily home weight, blood pressure, heart rate, and symptoms evaluation. And unfortunately, follow up at about 6 months, these patients did not have any difference in terms of returning back to the hospital system. How about fluid in the lungs? We talked about that a little bit. Let's take a look at DOT-HF. DOT-HF was an audible alert for patients who had an ICD, who had fluid and increased thoracic impedance, and the alarm would go up. And as you can imagine, what would happen is that as the alarm goes up, the patient would call in, and if it's after hours, it's to the PCP or the cardiologist. Chances are the recommendation was come back to the hospital. And that's indeed what happened. These patients ended up coming back to the hospital a lot more than the control arm. So we crossed this out. We said thoracic impedance with an audible alert, that doesn't work out. Let's get rid of this audible alert because it's the Chicken Little moment, right? And getting patients back into the hospital. All these patients ended up coming back to the hospital. But perhaps the idea was that we were not proactive, that we were reactive and inexact. And I think that we talked about this a little bit last week, so I won't spend too much time on this. But the hospitalization, if you were to trace these steps backwards for a patient, oftentimes they'll get symptoms right before that hospitalization, obviously some weight change right before having symptoms. But prior to that, you'll get thoracic impedance changes. That's why we thought maybe thoracic impedance following and monitoring would help. But we're thinking maybe the filling pressures. That's where the gold mine is that if we can get to the filling pressures, we can be proactive and actionable rather than being reactive and inexact. So that's what CardioMEMS does. Talked about this again last week, so I won't spend too much time on Champion or guide. But CardioMEMS is a device that's placed in the pulmonary artery. It's about the size of a dime. Let's take a look at the pulmonary pressures. The reason why this is important is because if you take a look at hemodynamics, we rely on hemodynamics. Heart failure doctors ought to be the best hemodynamic physicians in the hospital. And as we rely on hemodynamics, we have to understand what we're looking at. So a CardioMEMS device will be placed at a bifurcated PA location and pulmonary artery location, and that's measuring all these pressures, right? And that's what we'll take a look at. And if we're measuring the pressures correctly, what we're assuming is that the PA diastolic pressure is somewhat equivalent to the mean or wedge pressure. And if they're equivalent, then the PA diastolic pressure should give us a good sense of left atrial filling pressure, hence left ventricular end diastolic pressure, or what the filling is for the LV. And that's important for us in these patients with heart failure. I'm going to skip this video. That's an implantation video. What we're looking for are these trends. We get systolic, mean, diastolic trends, and we're trying to shut the numbers all the way down to where that gray area is, where it's more optimal in terms of the pressure readings. The pressure readings are optimal in our institution. Our systolic blood pressure of about 15 to 35, diastolic of 8 to 20, and a mean PA of about 10 to 25. That differs depending on the type of patients that we're dealing with. The pivotal trials of CardioMEMS, and I'll set this up. Kelsey ended up placing my PDFs on the chat, so feel free to have at it. So I'm not going to spend too much on the clinical trials. We may have spoken about that a little bit last year, but very quickly we ended up going all the way from our seminal champion trial, and we've had most recently a lot of European trials that have come through as well too that have decreased readmissions tremendously. The champion trial took a look at 550 patients. Every single 550 patients got the CardioMEMS device. The randomization is whether their physicians and their providers, their NPs, and the nurses are able to see the waveforms and the pressure readings or not. That was the randomization. And what we found was that there was a big benefit in patients who had CardioMEMS plus guided care. And the group that had CardioMEMS but were blinded, the providers were blinded to the pressure readings, didn't have that much of a benefit. So readmissions matter. Readmissions, CardioMEMS was very helpful for readmissions. I can share with you that baseline creatinine had nothing to do with it, whether the patient came in with a GFR that was very, very low or a creatinine that was very, very elevated. It really didn't matter between the two groups. It was very safe because of the diuretics and the other medications we were giving these patients. Patients who had HFpEF benefited the most. If you take a look at the numbers of HFpEF, these patients ended up having a dramatic difference between patients that were treated with the CardioMEMS plus open data versus control group with closed data. The first 5 patients at UCSD that were implanted were HFpEF patients. The post-approval study, you can see a large difference with heart failure hospitalization in the US, and we're talking thousands of patients. In the MEMS European study, we saw the same thing post-approval. After about a year, we saw a reduction, massive reduction in readmissions for our European patients as well too. We also saw some survival benefit retrospectively. This is an optimized GDMT subgroup in the champion study, but this is retrospective. We saw survival benefit in these patients as well too. We did a match propensity cohort. Jacob did when he was over in Portland, and you can see here that this was that you can see some different. I'm sorry, this is Dr. Gerbitz's data, but you can see that within Medicare database that the treatment group showed a signal of reduction of mortality as well too, and that's significant. That's very important for us to know. But again, this is all retrospective. So with our gentleman, we ended up implanting a CardioMEMS in him, and we were able to get him to 0 heart failure rehospitalizations. Again, this is back in 2018, so it was a while back, and he's doing quite well and living with well-compensated cardiomyopathy. Sometimes, though, CardioMEMS doesn't work and doesn't help. This is another patient that we have that's intermittently had housing insecurities and was in between being homeless into shelters and also with family members. So sometimes it doesn't help out with some of our patients. So patient selection is very important as we think about moving forward. The Dutch Monitor HF trial took a look at a randomization, but it was open label, whether the patient had CardioMEMS or no CardioMEMS. Remember, that's different than our original champion. This Monitor trial did show that there was significant KCCQ benefit, so quality of life was improved in patients who had CardioMEMS, and also heart failure hospitalization improved as well too. So heart failure hospitalization dropped 44% in our CardioMEMS patients, and that's significant. That's a bigger number than our champion trial. Remember, we're comparing apples and oranges when we're comparing trials, though, because this is a trial that was open label. That led us, if you remember, the survival signals to GUIDE-HF. GUIDE-HF was a study that took a look at thousands of patients coming in with CardioMEMS that are fitted very similarly to Champion, but we're looking now with a larger number to establish mortality benefit. And this is what GUIDE looked like at the turn of the decade as we were trying to enroll some of our patients into the study. Unfortunately, we did have a nationally declared emergency, as you remember back in 2020 with COVID-19, and that really played a role in the analysis of GUIDE. GUIDE showed us that if you concentrate on the left-hand side, that although there was a benefit, a signal of benefit, it did not reach statistical significance. If we took out all those patients after the closure of the country and took a look at pre-COVID patients, you do see that statistical significance. However, take it with a grain of salt because remember, we're picking data here. So it did lead us this time last year to a Centers of Medicare and Medicaid Services. We did get a national coverage determination for CardioMEMS, and hence you see a lot of numbers go up for CardioMEMS in terms of implantation. So for us in our institution, we take a look at CardioMEMS. We have a very simple indication quiz. We take a look at a New York Heart Association functional class 2 or 3. This is regardless of LVEF or CKD. And either it's an admission for heart failure within the last 12 months or an elevated natriuretic peptide. So as you can imagine, our nurses got the ability to speak to a lot of our patients who are admitted with heart failure about CardioMEMS pretty easily. A lot of them had a lot of practice because of this huge net that we were casting for CardioMEMS. Contraindication, unable to take DAP therapy for 1 month after implant. So ordering CardioMEMS at UCSD, it's pretty quick. We have a dot phrase that's available in the PDF as well too. And this dot phrase is justifiable. This is a dot phrase for those of you who don't use Epic as your EMR. This is a phrase that pops up whenever we put dot CardioMEMS, and it justifies for insurance and the payers the ability to get this device. Our workflow is very crucial, right? How do we do it here? And which is very different than some of the other places that I've been to and given this type of a talk. The first 2 weeks, it's daily monitoring. We're monitoring the quality of waveforms, taking a look at morning values if we can. We're taking a look at values of respiration and positional, diurnal variations. And then after the first 2 weeks, then we set our goal and we monitor by exception. We have a nurse that takes a look and figures out whether the patient's at goal, whether it's 5 up or 5 down, then we intervene accordingly. Every Wednesday morning, we have a huddle, and this is not done in all institutions. In fact, I don't think any other institution does this, but we have our CardioMEMS nurses and our PAs get to the table and present some of the outliers to me. And our heart failure nurses, our remote monitoring team, Karina and Jessica, and then our heart failure nurses, Teresa and Joanne, are involved in this as well too. They report this to me, and I send off quick messages to my colleagues because not all of these patients are my patients. So send quick messages. We're going to go and increase torsemide on this patient A, and then we're going to increase Entresto on this patient B. We're going to dial back on dapagliflozin on this patient C. We're going to increase spironolactone on this patient D. And then I call the other MDs via texting or whatnot, internal texting with our secure chat. And we'll also have our IT guy, Tushar there, he's very helpful in trying to get the workflow through. And Abbott, we've invited Abbott as well too, to take a look at some of the device-related issues with our CardioMEMS. So we do this for about half an hour every Wednesday morning. That's worked out pretty well for us. One of these spoke hospitals that we're involved with locally, we're at UC San Diego. We have many spoke hospitals as we're the hub. And we go to the spoke hospitals to help with different types of devices. And one of the spoke hospitals, we were able to start a CardioMEMS there for the team. And this is a look. This is their first 2 years in implementing CardioMEMS. Take a look at heart failure hospitalizations. There are 55 heart failure hospitalizations prior with these patients. These first, I think, 20 patients or something like that. And then after the implantation, CardioMEMS only 8. So huge reduction in heart failure hospitalizations. The length of stay is decreased as well too. So in this experience, at one of our spoke hospitals, a significant decrease with heart failure hospitalizations and decrease with length of stay. When you take a look at the average cost of the hospitalization and length of stay and internal analysis, and this is something that the industry can do for us. We don't have to have our internal metrics to take a look at that. With these 26 patients, they've saved about $500,000 with the heart failure hospitalization. That's the length of stay, and that's also added on the cost of the device. So this is one hospital. It's one of our referring hospitals. So take that with a grain of salt. It's not an academic tertiary quaternary center. Our numbers are a little bit lower than that. We do have hundreds of CardioMEMS patients, but our number is into the hundreds of thousands, not 500,000. So what are some of the other biomarkers that we follow and some things that we can follow while these patients are at home? And we have a Cordella device that's very similar to CardioMEMS. We talked about that last week as well too. The Cordella device involves the Indotronics sensor and also a blood pressure cuff, a weight scale, pH saturations, and also a tablet so that patients can place how they're feeling as well too. That's with Edwards right now, and that's an option for patients as well. How about ICDs? We took a look at thoracic impedances with ICDs, but can we change that? Can we expand thoracic impedance? Multisense, right in the middle there in 2017, was a study of HeartLogic, a Boston Scientific software, to take a look at heart sounds, right? You have an accelerometer taking a look at the first heart sound, accelerometer taking a look at the third heart sound. And if you have an increase of the third heart sound in S3 or diminution of S1, that means something. That means that your patient could be in worsening heart failure. We'll put in thoracic impedance there. Respiratory changes, if the respiratory rate has increased or rapid shallow breathing is present, then maybe there's some respiratory component to this as well too. Again, a lot of these metrics will precede some of the symptoms that we would see in clinic. Heart rate variability is very important as well too, or some sort of heart rate issue in terms of arrhythmias, and also physical activity. So what Boston Scientific did was to take all of these parameters, all five, and marry them together to a score, a HeartLogic score. And the idea is to get the HeartLogic score down. If you have a patient that's trending up, then let's call the patient and see if we can get them down. This is very beneficial for patients who already have the ICD. We have another means of measuring these patients. This is the Zoll device. This is our microcord where it is placed, anybody that's coming with heart failure, it is a patch that is placed in the left axilla, and it measures not really thoracic impedance alone, but also measures a lot of heart rate issues as well too. So this is not an invasive device. It's a percutaneous device. And what you can see here is that we have shown in the VMAT trial that there's a relative reduction in heart failure related hospitalizations, rehospitalizations with this device. So more to come with that. And novel wearable sensors as well too. Where we're going with wearable sensors is so ubiquitous. There's a ton of data out there right now. If you're going to ACC, there's going to be a lot of information about novel wearable sensors as well too. I personally don't have an Apple Watch. I have a Garmin watch because I do a lot of running, and that measures everything for me. So more data to come. We also have Nightingale, which is something that part of our research here at UCSD and my good friend Kevin King. And Nightingale is a scale that's placed under the bedposts. And it's taking a look at weight changes, but it's also taking a look at respiratory variability. And what we found in patients with heart failure that get into rehospitalization, they tend to have respiratory variations and quicken respirations fairly quickly. So more to come with this, but we're trying to get out of the invasive sense and into the more non-invasive world. There's remote speech analysis as well too. This is a study that was done in Israel, I believe, but it's a acutely constipated heart failure patient that comes to the hospital. They get this app where they record 5 sentences. It's a voice analysis application. And the idea is that this voice analysis will measure certain different things. And some phonation differences will give clues as to whether patients are in heart failure or not. We have digital care programs like Medley. I won't spend too much time on this, but this is a third-party provider where they take a look at symptoms, heart rate, blood pressure, and weight variability as well too in our patients. And it puts all that information together and provides it for our team. So it's a Medley nurse coordinator that puts all this information together, and all that information comes to us, the cardiologists, the PAs, and the NPs. I won't spend too much on digital health platforms with Story Health. I'll get back to that if I do have time. Now, when our patients are at home, the question is, well, what can we do for them? In some states, you're able to get our nurses and give IV diuretics at home. We don't have that at UCSD, but we do have Furosix, which is a furosemide on-body infuser, and many of you have already used this. And there's some success stories. In some patients, you've got to stack doses together in order to be able to get a good response for your patients. We also have this, Embumist, and this is from Corstasis. This is a bumetanide intranasal that is supplied a lot like naloxones and some of the anti-opiates out there. So the idea is to provide a fairly good bioavailable dose of Bumax into our patients. This is live right now here at UC San Diego. We can order this, and we can get our patients home. They can get this diuretic dosing intranasally. So let's talk about Homestead. Homestead is a three-part triaxial program taking a look at ER to home patients, patients clinic to home, and patients in the hospital to home quicker. The idea is that this is already here, by the way, a hospital at home. But the idea is that we are going to be able to supply these patients with daily telehealth visits, daily home nursing visits through our population health with lab draws if able. We have partnered with our clinics and our urgent cares and not our express cares, only our urgent cares and our clinics to be able to provide IV diuretic delivery for our patients. And then the reason why the urgent cares are there is because of after hours and into the weekends. And we have weekly in-person heart failure clinic visits with myself. We have weekly remote monitoring clinics if these patients do have some of those devices and softwares that I've discussed previously. And the idea is this is a study that is taking a look at patients coming to the hospital and having a fairly regimented schedule when they're at home. They're going to be visited by a nurse at home. They get intravenous loop diuretics if you are able to do that. We can't do that at UCSD for a lot of different reasons I won't get into right now. Or we get Furosix, we get bumetanide intranasally for some of these patients. Or we get the analysis. Their weight's doing okay, their lab's doing okay, then maybe they don't have to come in to the clinic. But if any of those parameters are off, or if their cardiomems are off, then they're invited into clinic, go straight in, no waiting, and they get their diuretics, IV diuretics, and their lab drawn to us. In some patients, we can do a physical exam while they're in clinic as well too. So this is our clinic to home. This is the first phase where a CARDS MD identifies a patient that is volume overloaded. Usually what used to happen in 2023, 24, and prior to that was that if they're volume overloaded, let's give them a shot of diuretics. If they don't respond well, let's get them into the ER. As you can imagine, that's a path we don't want our patients to take, and they don't want to take that. So what we do is that our cardiologists can enroll these patients in clinic to home, which means that they can get their first IV diuretic dosing. They come in successively for successive IV diuretic dosing. I own these patients then every single week. I'll see them on that Wednesday right after my remote monitoring clinic, and I evaluate their labs, right? So our nurses take a look at the labs. If the potassium's low, they'll give me a call. If the creatinine's going up, they'll give me a call as well too. If their sodium's going down, they'll give me a call as well too. So the idea is that with that one patient, we keep him out of the ER and potentially out of inpatient. So this is our first phase, and that was the easier phase to start. And what we were able to do, what we found pretty early on as well too, is that we can invite our pharmacists into this. And we have a very strong pharmacy team that's led by Trina Huynh, who's in the middle there, and also with Andrew Williford. Our pharmacists now have a integrated heart failure clinic with us. That is to say that in our clinics, we identify a patient with heart failure that are not on GDMT. We activate our pharmacy GDMT team, and these are phone calls that the patients get. They get to see me or any of my heart failure colleagues in clinic, but our pharmacists help in trying to up titrate the GDMT for our patients. And what we found was that it was a whole lot easier when the pharmacists are involved in getting GDMT, and we're getting close to about 60% currently. So in about 3 months, we're able to get them about 50% or so of GDMT. That's quadruple therapy, 4 pillars of heart failure. But now we're getting closer to about 60%, and that's a huge change compared to the historic cohort where our numbers are about 30%, which is not dissimilar to a lot of the other academic institutions. The second phase of this was ER to home. Okay, so we've got clinic that works, that makes sense. How do we apply this to ER to home? At ER to home, and we have to thank our population health colleagues for this, but ER to home, we have an ER doctor that says this patient is appropriate for Homestead. They'll send an order out. I get involved, but the ER follows these patients every single day on telehealth. And these visits happen every single morning, so long as telehealth exists, right? And so I won't get into that. And these in-person daily visits from our population health team is going to be very, very helpful. We have our nurses come in, and these doctors call in every day to check on our patients, and it's all virtual, um, uh, a virtual monitoring visit. And if the patient needs Cyrex, they come in that day into clinic, and the ER doctors are able to provide them with diuretics and lab draws that very same day. Our heart failure nurse, you saw our heart failure monitoring team. That's Carissa and Karina, I'm sorry, and Jessica, and they were able to take a look at these patients on a daily basis, calling them, making sure they're okay too. So two layers of support there. And then every week, I get to see them for about a month and making sure that they don't need to come back to the ER. And then after that month, I've seen patients for 5, 6 weeks at a time just to make sure that they're doing okay. And a lot of times it's just reiterating pill boxes and all that stuff as well too. But seeing me once a week, and if need be, IV diuretics when they see me as well too. These are our exclusion criteria for ER to home. So we're fairly particular and very picky, and these are the types of patients that we won't exclude. Any patient that's part of the advanced heart failure team, they'll give us a call about, but they're not going to be placed onto this. We do have mechanisms within advanced heart failure that we can see these patients sooner and more frequently. This is our population health team that I've worked with, and I have to give a lot of thanks to them as well too. It's a lot of heavy lifting. So big thanks, particularly to Lindsay, who's put this through. This is our last phase, hospital to home, and that's involving patients that are already admitted. Can we get patients who are already admitted who would otherwise stay for hospitalization for about 5 to 6 days? Can we get them out of the hospital earlier? Because in clinic we can diurese them, or at home we can give them Furosix and we can give them some bumetanide. And a lot of patients would sign up for this because they want to be home and they're more comfortable. And there's a lot of studies showing that patients recover better at home. We have the help of VTalk, which is our Video Transitions of Care MD. That's the hospitalist team that follows up these patients on a daily cadence. The heart failure team, we don't have enough bandwidth to be able to do that, so we partner up with our hospitalist team, and our hospitalist follows up with these patients, and they take a look at after visit summary gaps. If their medications are off, they're not taking the medications the right way, remind them that they're going to come back in for a CT of the chest or a chest x-ray or that echocardiogram they're supposed to take a week from now. Keep that telemetry patch on, right? So all those little things that are very worthwhile. So our hospitals play a big role in that, big role in that. They get a daily call from our heart failure nurse, that's Karina and Jessica, our PA, and then they get to see me Wednesday in clinic. So if you get discharged on a Thursday or Friday, they'll see me the following week. If they get discharged on a Monday or Tuesday, they'll see me that very same week on that Wednesday. And we're using our UCSD marker score, and that's something I won't talk about too much. So after the application of this, and I took over as director back in 2023, and end of 2023, you can see that our numbers are fairly favorable, and our readmission numbers have dropped. Very seldom are you going to be able to see length of stay numbers drop, mortality drop, and also readmissions drop, but it did for us. And we're benchmarking ourselves to the top 20 hospitals of U.S. News and World Report. And more eyes in substantive monitoring, I think, is the key for a lot of our patients and keeping that home and keeping them home safely. All right, with the time left, I'm going to skip this slide, but I do want to thank our Homestead team. That's folks that you've heard about already, Karina and Jessica. Our video visits, hospitalists, we have Laura and Laura, who are in the clinics. They are the supervisors in our cardiology clinic. That's myself and Tushar. I don't have great pictures of everybody, so I apologize. I use Microsoft icons. The reason why I like to present these things in the last minute or so is that we were faced with a lot of adversity prior. and we're able to push through. The big adversity we have here now is beds, but we're going to have to push through, right? We did it with COVID-19, and COVID-19, we had an expansion of vaccine research. We ended up taking over Petco Park to have a vaccine superstation. We have mobile vaccinations as well too. We have some California notify exposure notifications as well too. We had test kits that were given to our students at UC San Diego, and we also had community engagement as well too. So that was a huge effort. We're able to do that. We're able to push through, and I think we need to be able to push through now with the lack of hospital beds that we have. And this is what our team used to look like, but since taking over, what I'm really big at is leadership and all this stuff. So I ended up crossing all this stuff out. What I ended up doing was to push for a different type of leadership. I won't talk about our IV diuretic protocol too much, but if you're interested, data's there and I can talk to you more about it. What I ended up doing was to create a team that's based on inpatient, based on GD&T, based on outpatient, based on heart failure education. And I based that on two books that I really love to read. That's General Stanley McChrystal's Team of Teams and also Tribal Leadership. That latter book by Dave Logan, if you haven't read it, please read it. It is a very good book for anybody that's interested in leadership or is currently a leader. What I ended up doing is triading all of my team members. I had an inpatient team led by Dr. Kim Hong, with a pharmacist and an NP and a nursing champion. I had an outpatient team that was led by Dr. Quan Bui, a heart failure cardiologist, partnered with our clinic supervisor, Laura, and a general cardiologist, Dr. Frenner. I had an outpatient team that was championed by Hillary Shapiro. And as you can see there, our remote team, Jessica and Karina. And then finally, I had Dr. Ben Cruz and Antoinette Beers as the champions of the GDNT committee with our pharmacist Trina. And I also asked that they report in between each other as well too, and not to silo everybody. So the report in between is a report between the champions of each of the groups. And that was very important to me. I had to embed each of the triads. So in summary, we found that early telemonitoring trials were disappointing. Our collective experience taught us methods to improve remote monitoring. In order to manage patients at home, the measured marker needs to be accurate, substantive, and precise. Evaluating subsequent change and measurement should be easy and reliable. Measuring lung fluid content and cardiac filling pressures have shown to be the most benefit so far. We have lowered risks. Patients may benefit from multi-parameter scores. That is the Boston Scientific software with HeartLogic. Hospital systems were nimble during COVID-19 pandemic, siphoning inpatient resources to buttress outpatient activities and deliverables, and we ought to do the same with our inpatient crisis now. And what's really important too, and I didn't touch base on this, is the addressing of the healthcare inequities. That's going to be crucial. Not everybody that's going to leave has an iPhone, right? Or some sort of Android device that they can really rely on. We have to be very sensitive to that. So with that, I am going to stop sharing. And I think there's a question that popped up. Oh, no questions so far. So questions.
Yes, and I believe Sue just put in the chat here, just to remind everybody, if you do have questions, you can submit them to Dr. Tran in the chat for us here. But I would also just love to ask you, Dr. Tran, kind of when it comes to the different, novel devices that you're seeing to try to treat these heart failure patients, do you guys run into any type of insurance barriers, and kind of what are some of the barriers that you've seen to some of these devices and getting patients enrolled in them, and how are you overcoming that?
We have we had difficulty initially back in 2014, 15, 2015, 16 with CardioMEMS. And that was very difficult. And going through that process was something that we said, all right, maybe this is not something that we want to go through. But slowly but surely, a lot of the insurance companies were able to jump on. What really made the big change, really for us, is taking a look at some of our authorizations now, is that national coverage decision that came through last year. That made it a whole lot easier for a lot of the payers to take a look at the benefit of CardioMEMS. And you can extrapolate that to the Innotronics proactive device as well too. So a whole lot easier now. Now, if we're talking about some of the other Barostim or some of the cardiac contractility modulation, which I didn't talk about, talked about last week. That's a little tougher for us to go through, but the industry folks are fairly helpful in trying to get our patients enrolled to some of those devices.
Thanks. And it looks like we have another question that came in. It says, did you have patient compliance challenges with CardioMEMS?
Yes, and that is a uh, big consideration. As you're coming in and figuring out, all right, what level of compliance? Not everybody's going to be 100% compliance. I had a cut when I was biking 6 years ago, and I didn't take all of my Caflex, right? And so, and but then again, Caflex was 4 times a day for me, but and I'm trying to make excuses for myself, but it was very, very difficult, right? Because we had to sit down and say, all right, well, we know this patient has issues, but we do think that as this patient has the ability to transmit. Uh, it's okay to get it twice a week, and we don't have to get it every single day. At least it's information for us to try to keep that patient out of the hospital. So I think individually in your own programs, you're gonna have to figure out if that's okay for you. For us, we had a patient that it's 42-year-old woman had two kids, two boys, very young boys, and she was actively using meth. And in most centers, you're like, no way, I'm not touching this patient with anything. But we sat her through, talked her through. She ended up having her kids get taken care of by a family member. And with a lot of compassion for this patient, we ended up providing her with CardioMEMS with the idea that if she cleans up, she's able to get through what she's able to get through. We'll LVAD her. And we did. 2 years later, we transplanted her. So she's transplanted now, and her kids are back to her teenage boys now are back with her, right? So it does happen, and I would one of the dictums that we have at UC San Diego is that we don't say no. We try to figure out how to get them to that point. So instead of saying no, let's figure out how. And I hope that you would practice that in your institutions as well.
Thanks. It's a great story to learn from. Another question we have is any barriers to FUROS6? Our patient population is wide range and we worry about the 60, 70, 80-year-olds being able to use and follow the directions correctly.
Yeah, Sarah, 100%. I think the FUROS6 industry, they're very helpful as well too. And that's a great question. I have FUROS6 running twice a day on one of my patients who's 80 years old. And it really depends on your patient. I think that there's some patients that I wouldn't apply FUROS6 to, largely because I don't think that they're going to like to have being stuck by a needle, even though the needle's embedded into this cartridge. So that's going to be very important as well too. And for us, we're fairly, we walk the patients through, the nurses walk them through, and then if there are issues, then the FUROS6 will walk them through that. The intranasal BMX, that's relatively new. That's a couple months new for us, and it's fairly easy. And I tried it without the drug, and it was a little irritating to me, but we'll see more data to come with that.
It's dedication.
Yeah.
All right. Another question we have is, will non-invasive devices eventually replace invasive solutions if they can replicate the same sensitivity and specificity as PA pressure sensors, in your opinion?
Yes, 100%. I think that's something that we look forward to, and then hopefully we'll get to the point that non-invasive is going to help. There are different ways. I didn't talk about some of the other devices that are in the pipe, but they're down the pike, but they're devices that people wear belts, right? And this is something we haven't proven yet, but we'll get there eventually. And the less invasive, that's the way to go in the future.
Great. We have another question here that asks, for a smaller health system with fewer resources, what would you recommend as a primary step for follow-up of CHF patients to decrease admissions, daily calls by a nurse, or clinic visits a couple of days post-hospitalization?
Diana, this is huge. And I can share with you the spoke hospital that I gave that illustration. That spoke hospital that saved $500,000 based on the 26 patients with CardioMEMS. They had very low amounts of resources, but they had a champion. They had a cardiologist that really believed in this and really felt that this was going to help. I think looking for a champion matters. I think there's some nephrologists that want to be champions of their dialysis patients because they're always figuring out how much fluid to take out for our patients. So I think having a champion, within the health system is very important. That's how you really push things through. And not knowing a lot about your institution and your health system, I think finding that champion to be able to say, I want to move forward with remote monitoring, that's going to be helpful. Whatever work you do, though, whether it is in the capacity as a nurse or a capacity as an MD, DO, or a PA, MP, um, it's going to be appreciated by your patients. It's something that we can offer. Just because we don't have the data to really back it, you should offer it still. The VA does that. Our VA has daily calls to patients, and we've shown that that hasn't really been helpful. But at the very least, the patients are closely monitored and they're followed in a nice fashion. So do something. But I think that when you're taking a look at substantive changes, we've shown it with CardioMEMS, and we've shown it with the MicroCore and some of these other devices. And eventually we'll get to non-invasive, more and more non-invasive devices, but just not yet.
Yeah. And it looks like I think that's all the questions that were submitted. But again, if others have follow-up questions for Dr. Tran, my email is on the screen. Please feel free to email me, and I'd happy to get those over to him. But if there are no other questions, I'd like to just remind you guys again and thank you for joining us today. Oh, did we get one more in maybe? Oh, just, yeah, thank you from Dana. Yeah, so I would just like to thank you guys for joining us today for this Lunch and Learn series. I hope it was helpful. And I'd encourage you again to join us next week on Thursday. We'll be hearing from Sarah and Carrie, who are two nurses at the Nebraska Medicine, who are going to be sharing their nursing pathways for strengthening heart failure care. And then the following Thursday in February, we'll be hearing from Dr. Bennett and Sarah Kaspari from Allina Health Minneapolis Heart Institute on their EPP-led heart failure clinic and automated referral pathways. So again, I thank you all for attending. Please take the time to complete the survey after this event because it really does help us as we build more educational opportunities to hear what's helpful and what you guys want to learn from us. But again, thank you so much for joining us, and we'll see you next week.